try to present just a broad sketch of some events that have happened in the U.S. institutions over the past 200 years. When I saw Kim's title of Transformative Approaches, I'm afraid it's going to be kind of light on therapy. I don't know much about the therapeutic revolutions of the institutions, but I can talk a little bit about politics. And as promised, I'm going to talk a little bit about Walter Freeman and lobotomies. Let's see, I'm going to try to, there we go. Okay, so 4 revolutions, basically. I'm going to cover the establishment of the state institutions in the late 1800s. And then the promise of a revolutionary treatment that emerged in the mid-1900s. And it actually emerged at about the same time the deinstitutionalization movement took off. Some of you might be familiar with that. I'm, of course, going to address the collapse of this promise of the revolutionary treatment. And then I'm going to try to walk us from the beginnings of the deinstitutionalization movement, which started as far back as the 1940s, up through today. And I would be more than happy to invite some of the clinicians who are here to provide more recent details about what has been going on. They might be more expert at it than I am. The Enlightenment itself, as we know it, was sort of a continuation of the scientific revolution, a scientific revolution that encouraged people to turn their minds outward and begin to place less faith in authority or in the aristocracy that governed them. This is particularly in Europe and Western Europe, of course. The Enlightenment took off, first of all, because in many ways the scientific revolution paid off by being empiricist, by observing the world and by measuring things and by noticing patterns. Things like navigation, understanding the movement of the stars and how navigation revolutionized travel around the world, demonstrated that, you know, if you pay attention to what's around you, you can do things. It's good for the economy. So the leaders of particular areas would sort of step aside if they had a scientist who promised them riches as a consequence of exploration. And of course, the understanding of cause and effect relationships, in fields like chemistry and physics were very inspiring. And the challenging of the authority of the church and the monarchy also. So art, law, and medicine begin to break the bounds of the imposed authorities of the time. And then as medicine emerges, there is a mechanistic approach to medicine. If our physical bodies are part of the physical world, and if they seem to be made up of all the components that we understand in the physical world, if they obey the laws of physics and chemistry, perhaps we can understand more about living things by treating them in a mechanistic way. So if the body is a physical thing governed by physical laws, then we stand to gain a lot by looking at the operations of the body. I'm sorry, I have to move my Zoom caption. It's covering some of my slides here. But is that early medicine that I've got there? Yep. So early medicine, I want to give a quick shout out to Joseph II. I don't know if any of you remember the movie Amadeus, but Joseph II was the loosely the King of Austria, but would you call him the Emperor of the Holy Roman Empire of the time, or what was left of it at that point. And Joseph II was a very forward-looking monarch, and he established a military academy of surgery, because any good monarch needs a standing army, and if you're going to have a standing army, you need to keep your standing army healthy. And to his credit, he noticed patterns of disease. He established hospitals and understood the importance of keeping individuals with contagious diseases quarantined and isolated in the hospitals. And at the Vienna hospital, he also mandated autopsy with every death. Now, I'm sure this came as along with recommendations from his physicians, But if somebody walked in and just died, they were going to take an opportunity to explore and learn what went on. And there is a fascinating book written by Eric Kandel, who is a Nobel Prize winner in the field of neuroscience and psychology. And Kandel does a great job describing the history of Vienna and the history of autopsy, and how the history of autopsy and the practice of autopsy itself kind of opened the door to understanding human nature, or at least encouraged us to ask questions about human nature. Because what an autopsy did, literally and metaphorically, is it often showed that what was on the surface could look fine while horrible things were happening deep inside. So the practice of autopsy, the desire to understand what could be going wrong inside a body, beyond what you could see on the surface, inspired artists, inspired people like Sigmund Freud, who, of course, that was his whole thing. The belief that that what you saw on the surface of the mind, what somebody was explaining to you, was not necessarily a good way to get to the core of what was going on. So to kind of summarize, we owe a lot to Joseph II for establishing the Vienna Hospital and the practices at the Vienna Hospital. So medicine aspires to become scientific. And as I often tell my students, and as I'm sure many of the physicians here know, the early history of medicine is more about describing and understanding than it is about treating. The earliest doctors spent much more of their time just looking and trying to figure things out, and sometimes could not come up with a treatment at all, but simply be understanding differential diagnoses, being able to predict what was going on by doing things like listening, the advent of the stethoscope. I know Jerry could probably tell you more about that. So as medicine becomes scientific, we're also challenging authority in another way and saying that ailments, illnesses, whether it's an illness of the physical body or an illness of the mind, is not it's not a result of a moral failing. And so the practice of medicine is in a way challenging authority by dismissing the traditional explanations for illness and disease. So again, physicians are being encouraged to look for causes and assume that the diseases and the symptoms that they're seeing are products of the regular laws of physics. So let's jump to Dorothea Dix. Dorothea Dix, as many of you might know, revolutionized mental health care in the United States. She comes from New England. She comes from a Unitarian background. There's a long Quaker tie-in too that I don't have time to get into, but there's a particular local interest there. And she herself probably suffered from depression. She was wealthy as a consequence of her mother's family and had a lot of time to spend looking after the poor in her neighborhood. She has a disastrous home life, winds up getting sent to live with her maternal grandmother, and again has enough money to kind of do what she wants. And what she wanted to do was investigate and support individuals who were suffering from mental illness. So she goes almost state to state at that time, advocating for better care of the mentally ill at the time, who were often, often in prison, often in the worst parts of prison, and sometimes even were privately like families would privately contract people to basically imprison their mentally ill relatives. So she witnessed these horrible circumstances, and she petitioned the government at the time and called for government intervention and government support for the mentally ill. There's another story about her contacts and her travels to England, where she was inspired by what was happening in England at the time. But interestingly, this was at the time of Franklin Pierce. Trivia question, who was the president of the United States after Franklin Pierce?
Okay, Shawn, I have no idea.
Okay, it was James Buchanan. So Franklin Pierce, James Buchanan comes between Franklin Pierce and Abraham Lincoln. But Franklin Pierce, I'm sorry, I should walk back. Dorothea Dix lobbies Congress, and it looks like she's gaining momentum at the federal level, and hopes to get a federal policy to take care of the mentally ill. And Franklin Pierce kicks it back at the states and says, you know, social welfare is just not the business of the federal government. So that is why the term state hospital is almost synonymous with a mental institution right now, because the states, Dorothea Dix goes back to the states, particularly states like New Jersey and Pennsylvania. Pennsylvania embraced Dix, and she campaigns state by state, and we have the establishment of the state's mental hospitals. One of the big ones is St. Elizabeth's, which is down in Washington, D.C., and these state hospitals are built on what's known as the Kirkbride plan. So Thomas Kirkbride is a Quaker physician from Philadelphia who sets up, I don't know if you can see the architectural footprint that I've provided here in this image, but the Kirkbride plan, again, Kirkbride and Dix share a philosophy. First of all, that mental illness cannot be attributed to moral failures, and that also that people can get better. And Kirkbride is very optimistic with the belief that fresh air, sunshine, and even labor can improve mental health. So these state hospitals were set up in such a way where if you see that design, the design would probably make an engineer cringe, because the design is not very efficient if you were talking about heating and cooling the building. But it was designed for the sake of maximizing sunlight and fresh air. So that is the belief that sunshine, fresh air, and even labor on the grounds. You know, the grounds could the individuals who are institutionalized could have responsibilities for building fences, tending farms, or caring for the sprawling grounds of the hospital. So you have funding and building of the state hospitals mostly from the Northeast to the Midwest. If any of you are familiar with like the traditional map of Big Ten football, that's where you see these Kirkbride hospitals. Not so many in the South, and a few on the West Coast. And the Civil War, of course, draws attention to the condition and the function of hospitals. And if there was an American historian here, they would also tell you how the Civil War turned the country into it turned the role of government toward the federal government and away from state operations too. But with the Civil War, the history of PTSD is an interesting one to follow. And there is evidence that something that we would now recognize as post-traumatic stress disorder was being reported and was being recognized by the physicians who were treating Civil War veterans. But of course, World War I is where the awareness really kicks in. There's a clear recognition of PTSD and the role that mental institutions needed to play in treating veterans. So bit by bit, we're getting more and more public awareness, government awareness for the importance of some kind of coordinated treatment plan. So the costs and demands of these institutions continue to grow through the early 1900s. Again, consider the aftermath of World War I and the influx of patients at the time. So now the institutions are starting to burst at the seams a little bit, and concerns about resources and staffing begin to come into play. And if you are attempting to manage one of these institutions, which patients are the ones that are taking up the most of your time? Which patients give you the most concern? And of course, it is the patients who are often the patients who are suffering from what we'll just generally refer to as psychosis. So these are going to be the most challenging patients. And they are going to suffer from things like delusions, the belief that they are being pursued by someone, or that someone is out to get them, someone is hiding in the next room, the caretakers are conspiring to get them. Hallucinations, especially auditory hallucinations that keep them up at night. And if the patients are being kept up at night, the staff are, of course, being kept up at night. But then also the issue of incoherent speech and inappropriate behavior, which frankly frightens the other patients in the hospital. So there you get an almost obsessive concern about what to do with and how to treat the patients who are suffering from psychosis. So understanding and treating psychosis becomes a priority as the resources of these institutions get stretched. So where do you begin? Who is studying psychosis? How can we approach the study of psychosis in a scientific way? Well, now we have to turn our attention to the experimental physiologists. Again, I'm just so tempted to run down all of these different tangents here, but we really must realize that the training of what we would now recognize as graduate school training, and certainly a lot of medical training. Europe was really the center of the universe as far as the United States was concerned, because very often individuals, there was no such thing as what we would recognize as graduate school in the United States. If you wanted to study physiology, or if you wanted to be a practicing scientist, you would have to go to Germany, and you would very often have to learn Germany. Oh, I'm sorry, you would often have to learn German to go and study physiology. Friedrich Goltz, and I would also say other German researchers like Fritsch and Hitzig, experimented a lot with dogs. Early neuroscientists learned a lot from dogs, especially the organization of the inputs and outputs of the cerebral cortex in mammals. Generally speaking, the back half of the brain is the input center. Information goes into the back half of the brain, and then the front part of the brain, the frontal lobe, is responsible for coordinating the incoming information and sending messages down the spinal cord and out. So the brain has this input-output organization that these German physiologists began to describe and understand. So working with dogs, Goltz and other physiologists of the time, and also any physicians who are paying attention, the cerebral cortex, this thing that we call the gray matter of the brain, can undergo a tremendous amount of damage without it being fatal to the individual. Now, what the individual is able to do is quite another thing. But this discovery allowed these physiologists to do isolated lesion experiments. That is, they would go in and they would just either cut up sections of white matter, they would remove sections of white matter. Sometimes they would douse sections of the brain with pure alcohol, and they could render it ineffective. And then the animal would recover, and you would pay attention to what the animal could and couldn't do. So the function of the brain, our understanding of the function of the brain owes a lot to what these individuals did. And it was discovered even in these experiments with dogs that dogs would be less aggressive if they had certain types of lesions. That is, when I say lesions, a lesion is kind of a generic term for damage or just brain damage. So if there's brain damage in the frontal lobe, sometimes in the temporal lobe, you could make these dogs less aggressive. Okay. In an isolated lab for a physiologist, that's kind of a curiosity for Goltz. Oh, the animal's less aggressive. But one by one, the physicians who are working in the institutions, even the institutions in Europe, are paying attention to what's going on. And you can imagine them perking up their ears and going, did somebody say less aggressive? Did somebody say quieter? So Gottlieb Bruchard, he was not German, he was Swiss. And he was the first to perform brain surgery on patients exhibiting psychosis, with the hope of reducing these symptoms. In 1888, I can't imagine what brain surgery in 1888 was like. But Brookhart goes in with the belief that the brain is modular, and modularity is something that word is something that's very important to brain scientists. And to say that the brain is modular is to say particular regions are responsible for different particular things. Okay, so you might be familiar with Broca's area. Broca's area is strong evidence that the brain is at least partly modular. Broca's area is a part of the brain that, when damaged, leads to difficulty in speaking, sort of what's become known as Broca's aphasia. So if Burkhardt believes that the brain is modular, he's imagining all of these different brain regions that are connected to each other. And perhaps psychoses and other mental illnesses can be a consequence of overconnection or underconnection between these brain areas. And although they are not sophisticated enough to enhance connections between brain areas, Brookhart goes, well, if I can go in there, I can maybe cut up and disconnect brain areas. So Brookhart goes with the hope that cutting the brain will break up overexcited or excessive connections. He treated 6 patients, and 2 of them died. One would think that would be the beginning and the end of the story. And all of the patients, even the ones that survived, had things like seizures and all kinds of problems, which probably were not reported fully. Nonetheless, Brookhart abandons this approach and interestingly creates kind of this international controversy, because the Russians at the time, you might be familiar with Ivan Pavlov and his work with classical conditioning. The Russians were, or at least the popular Russian neuroscientists were behaviorists who saw the brain as a much more broad, homogeneous, interconnected system. So not only were the Russian scientists appalled by Brookhart's work because of the questionable ethics, but it was also an argument that said those guys who were approaching the brain as a modular system have it all wrong. Okay, so Brookhart abandons the approach, and for about 50 years, the thought of going into the brain and treating psychoses by cutting someone up is just shelved. Carlisle Jacobson was a physiologist at Yale who, so the legend goes, there's some debate about whether or not this is how the information actually got out. But Jacobson was working with chimpanzees, and he would create what was called experimental neuroses in chimpanzees. And that is, he would, I'm really abbreviating this story, but imagine that chimpanzees are very trainable. You can train them to do particular things for rewards. So imagine you get a chimpanzee that's used to getting a reward, a piece of fruit for doing a particular task over and over again. Well, now imagine that the researchers, let's say you reward the chimpanzee with an apple after doing one thing. Well, now you reward them with, I don't know, a tennis ball. The chimpanzee has learned to expect the reward, the good reward of the apple, and now you're giving him the tennis ball. And the chimpanzees, get frustrated like a 3-year-old child would, and they begin to throw tantrums. And if you continue to do this, you basically messing with these chimpanzees and teasing them. The physiologists, the researchers said, we're evoking, or we're creating a neurosis in these animals. And maybe the neurosis that we're creating in these animals can be used as a model that we can then treat, with the hope of understanding how to treat neuroses in humans. Okay, so you have these chimpanzees that get experimental neuroses, and then by lesioning their brain, again, we're back to 50 years later, we're lesioning the brain. The frontal lobe lesions seem to treat these experimental neuroses in these chimpanzees, or at least they seem to make them calmer. So now we've kind of bridged the distance between those isolated physiologists working in closed labs in Germany to language that is inviting people to wonder if the research that has been done on the dogs and the chimpanzees can be carried over into medical practice. And of course, at the same time, you have advances in surgery. You have physicians who are removing tumors successfully and noticing the differences. You know, if an otherwise healthy person presents with a brain tumor and has that tumor removed, but if the consequences of the surgery led to collateral damage to the brain, their careful notes would have them realizing that damage to certain areas of the brain could calm someone down, make them more sedate. So now you have an accumulation of evidence that suggests that damaging the frontal lobe will influence the behavior of individuals. And that takes us to Antonio Igaz Muniz, another individual who is a fascinating individual, politician, surgeon, polymath. To his credit, I think he should be remembered for his work, his pioneering work in angiography. That is, injecting something into the bloodstream and then taking an X-ray and looking at the patterns of the blood vessels. So Muniz deserves great credit for that. But he also, the story goes, he was in the audience when Jacobson was talking about the way he treated the chimpanzees, and he now gets the idea to bring Burkhart's ideas back into practice. And he's performing a leucotomy. And this terminology, we're going to go from leucotomy to lobotomy. Leucotomy means roughly cutting up the white stuff. So he's cutting white matter to address obsessive thoughts. These physicians, these physiologists, they're imagining circuits in the brain. They're imagining these loops of electrical connections. And if you think about how many mental disorders are associated, or how many mental disorders can be explained with the metaphor of a loop. I have obsessive thoughts, the looping behavior. I'm exhibiting repetitive behavior. You have a loop. So Muniz is partly thinking that treating psychosis, treating obsessive thoughts might be a matter of cutting a loop, snipping a loop. And where does Muniz believe these loops are? The thalamus is a structure that is pretty much in the geographical center of your brain. And the thalamus is part of your brain it's kind of in the center of your brain, but it has these looping feedback connections to almost every part of your cerebral cortex, connected to almost all the rest of your gray matter. So Muniz hypothesizes that psychosis is coming from this loop between the thalamus and the front part of the brain, the frontal lobe. So he goes in from the top to snip those connections. And he drills holes in the top of the skull to cut the fibers. And again, I'm sorry, I'm speaking faster than my slides, but he's seeking to break these connections, and he's seeking to use this as a way to treat as a way to treat these patients. He reported on 20 patients and claimed to have a 60% improvement rate. You know, what was happening with the other 40% is a big question. But looking back 100 years, it's depressing to think of how disposable a lot of these patients may have been in the eyes of the physician. So the promise to treat anybody was probably enough to get you some attention, and probably enough to encourage others to follow in your path. From Muniz, you have Walter Freeman. Walter Freeman, who studies Muniz, idolized Muniz, and Freeman is working at St. Elizabeth's Hospital in Washington, D.C., And he is also, I believe it was eventually he was promoted to the chief of the Department of Neurology at George Washington University. And Freeman, using Moniz's techniques and beliefs, decides that he's going to attempt Moniz's procedure on a number of patients in the United States. Now, of course, Freeman has, again, there are so many different threads that I could run down here. Freeman has the patients at St. Elizabeth's as his primary concern, and he notices the patients suffering from psychosis at St. Elizabeth's. But as I'm telling you the story about Freeman and tying it in with the institutions, you must realize that Freeman is also treating and taking in what we basically walk-in patients, patients who are being brought in by family members, sometimes husbands. So in working at St. Elizabeth's and George Washington University, so there's St. Elizabeth's again, the classic institution, he recruited a surgeon, James Watts, to perform Moniz's leucotomies with him. So Freeman himself was not a surgeon. He was not qualified to do surgery. So he could advise Watts. And, of course, the story in retrospect, you often wonder how truthful it is, but the stories in retrospect really suggest that Freeman put a lot of pressure. There was a lot of political pressure that he applied on Watts to do these procedures. Freeman was really excited about the procedures, Watts less so. By 1942, between 1936 and 1942, Freeman and Watts had done 200 of these what you would call the Moniz leucotomies, where you're coming in from the top. You have to drill holes in the skull. You have to put the patient under anesthesia. So the recovery and the surgical demands were very high. That frustrated Freeman. That frustrated Freeman for two reasons. First of all, it made Freeman dependent upon Watts. And second of all, it made things complicated. It slowed things down. So Freeman wanted to find a faster way to perform the surgery or to get Moniz's effects. And Freeman, doing some studying, doing some homework, realizes that you can get to the brain through the orbit, and the orbit, the part of your skull that surrounds your eyeball, is much thinner than the skull on the top of your head. And it can be cracked with, something like a nail. And Freeman actually did this. He went down and practiced on cadavers to see how easy it would be to get access to the brain basically through the eye socket. And this is an example. Here are the orbitoclast and mallet that we have at the Medical Heritage Museum. These are replicas of the tools that Freeman used. And the first time I saw these things, the first ones I saw were Freeman's actual ones, which are at the Museum for the History of Psychology at the University of Akron. I was aghast at how thick the orbitoclast was. I mean, not that frontal lobe damage with a thick ice pick would be better or worse than a thin one, but it like I said, it got me in a very visceral way. And there's the mallet that Freeman would use. So Freeman, who's not a surgeon, he needs this alternative approach as Watts grew increasingly concerned, and eventually Watts left. He told Freeman he wanted no more part of it. It took him till about 1950 before he left. But Freeman saw this coming, and Freeman developed his own approach to performing these lobotomies with these two simple tools. Now, this simplified things because Freeman developed a technique that did not require anesthesia. Freeman would temporarily knock people out by putting electrodes on their head, putting them through like quick electroconvulsive therapy, and then taking the orbitoclast, taking that long ice pick, he would squeeze in behind the top part of the eye and that ridge where your eyebrow is, and he would just do a couple taps, break through the skull that way, and move the orbitoclast back and forth, sort of like a windshield wiper. And he would do that on both sides of the brain. And by the time the patient came to, now, the consequences of these actions, of course, you can imagine, varied greatly. But Freeman could do these procedures now in an office. Physicians would be horrified. Physicians of his time were horrified at the non-sterile conditions that Freeman was performing these procedures in. And there's the only graphic. I didn't want to show you the graphics of the patients, so you can go online and look at plenty of real photographs showing Freeman's patients and the condition that they were in while he was performing this surgery. But there is a graphic that shows you Freeman's approach. And there is Freeman at work, just, again, it's horrifying to think that this is being done in non-sterile conditions. The hammer and mallet aside, the environment is far from sterile. But then Freeman worked as a private practitioner and then went on a barnstorming tour of the nation's mental hospitals. How many of the people at the hospitals were completely aware of what Freeman's doing is uncertain. But I think that photograph is pretty damning. It's difficult to argue that the individuals at that hospital, that Freeman's approach was not completely understood by the individuals at that hospital. So Freeman goes pretty much unchecked until 1967, performs over 4,000 lobotomies in 23 states, many at these state institutions. And Freeman's work is, of course, now regarded as a national tragedy. So we can look back and say, how did it happen and what turned the tide? Freeman, all by himself, I could have done a talk just on Freeman and just his autobiography. He was certainly a self-promoter. He was certainly worried about living up to the image of his grandfather, who was a pioneering neurosurgeon himself. You also have to realize that Freeman's career is taking off at a point where the institutions are becoming more and more desperate over dwindling resources. And there's no denying that Freeman was protected by an insular medical community. Even if they did object to what they were doing, there was an unspoken, or probably a spoken, code that said you simply didn't talk ill of other physicians. And then, of course, advances in psychopharmacology. If you could come up with a drug that served as a sedative that was as effective as lobotomy, now the choice between doing physical damage in the form of lobotomy versus giving someone a drug, the choice now seems obvious. I would argue, though, that many individuals still are very quick to assume that the drug treatment can be turned on and off like a light switch. Other things that led to the discontinuation of the transorbital lobotomy. The deinstitutionalization movement, we tend to see it as beginning in the 1960s. The deinstitutionalization movement can probably be traced back to the 1940s. Life magazine, I don't know how old our attendees are, I won't ask, but Life magazine used to revolve around photographs. Photographs. Life magazine used to be big, and it used to feature excellent photography. In 1946, Life magazine points its cameras at mental institutions, and you have many mental institutions. Can you mute that, Kim? So you have these institutions being put on the pages of Life magazine in 1946, and America is getting its first look into what's going on. Coincidentally, in 1946, I don't know if this was coincidentally or not. I could see the movie theaters coordinating with Life magazine, but coincidentally, none other than Boris Karloff stars in a horror movie based on Bedlam, which is a notorious institution in the UK. Bedlam was actually short for the word Bethlehem, so the Bethlehem Institution. So Boris Karloff has a sensationalistic horror film about mental institutions. So in the 1940s, even though the deinstitutionalization movement takes some time to gain momentum, you have the Life magazine report, you have the Boris Karloff movie, and of course, 1946 is after World War II. The soldiers are coming home, and there is a tremendous awareness now of PTSD. And the National Mental Health Act of 1946 establishes the National Institute of Mental Health. You have the development of Thorazine, and the history of Thorazine goes back. I could do a talk on the history of Thorazine, but Thorazine as a treatment quiets the voices. It's a widely applied, successful antipsychotic drug, and it was for those of you who are interested. I didn't want to get into neural pathways, but it's a dopamine antagonist, and interestingly, there are a lot of dopamine receptors in the frontal lobes, and Thorazine might indeed be acting on the same places of the brain, or Thorazine might be having its effect by acting on the same places of the brain that these leucotomies and lobotomies were cutting up. Thorazine is marketed brilliantly, and as you see, these are real magazine ads that are addressing Thorazine as a treatment for senile agitation and emotional stress. There are even ads out there that recommend Thorazine as treatment for just illness that would lead to vomiting. Okay. So in the 1960s, with John F. Kennedy, again, one more story that I could have gone into. Rosemary Kennedy was one of Walter Freeman's patients. So when John F. Kennedy gets to the White House, John F. Kennedy brings an agenda of improving community mental health. And you have the Community Mental Health Act of 1963. The 1965, talk about, here's an interesting political story. The 1965 amendment to the Social Security Act says that the mental health costs now, roughly half of the mental health costs, which, AKA reimbursements, are now going to the federal government and to the state instead of the states. So you can imagine that this just pulls the rug out from under the feet of the state institutions. And the states are kind of forced to depopulate their mental institutions. Civil Rights Acts, again, I say the psychopharmacology. Robert Kennedy does a televised tour of a Willowbrook institution in 1965, again, exposing appalling conditions. In 1973, David Rosenhan, a professor of psychology, I believe it was at Stanford, does what's called the Rosenhan experiment. I'm sorry, and the Rosenhan experiment, Rosenhan told his graduate students to walk into hospitals and describe some very benign symptoms. Like go into the hospital and tell them that you hear a voice that says blip and see what happens. And Rosenhan demonstrated that you could get asymptomatic people to fake symptoms and get themselves institutionalized. And when Rosenhan demonstrated that these institutions were not very good at discriminating between people who have quote unquote genuine psychoses and people who were faking it, that was a significant blow against clinical psychology and psychiatry in general. Also, as the institutions close and the public has an opportunity to reflect on the institutions, you do things like evaluate the grounds. If these institutions were often sprawling with lots and lots of real estate, as the institutions close, people start eyeing up the real estate and saying, "Hey, I want to build a Walmart there." Well, you have to first wrestle with the fact that on these institutional grounds there were often large grave plots, and there are some 5,000 bodies buried on the grounds of St. Elizabeth's. So, in retrospect, as people reflect on the fate of these individuals at the institutions are cast in a very dim light. So where are we today? Again, I think I probably have guests here who could speak better to where we are today. But we do still have Pennsylvania state hospitals. Pennsylvania, Dorothea Dix had a tremendous impact in Pennsylvania. Many of you might know that Harrisburg Hospital was one of the first institutions to be built. And we still have institutions at these 6 locations. And that is the mission statement for the Pennsylvania state hospitals right now. And I'm running short on time, so I'm going to try to wrap things up. There's lots and lots of other stuff that I could talk to you about, lots and lots of stuff that I could recommend, but little tidbits that I didn't have an opportunity to delve into. But Moniz wins the Nobel Prize in 1949, largely due to the campaigning of Walter Freeman, who was telling everybody what a great man he was and what a great procedure this was. Rosemary Kennedy, sister of John F. Kennedy and Teddy Kennedy and Bobby Kennedy, was lobotomized by Freeman and Watts in 1941. And that fact was not known to the Kennedy family until the 1960s and was not known to the American public until Doris Kearns Goodwin published a biography on the Kennedys in 1987. If you want a fascinating story about someone who survived lobotomies and lived to tell about it, I highly recommend Howard Dulley's book, My Lobotomy. Howard Dulley was lobotomized because he was a rammy 12-year-old at the recommendation of his stepmother. And Howard Dulley, to listen to him interviewed, you might not suspect that he was of high intelligence, but he's certainly articulate enough to tell a very compelling story about his experience. And I actually had a student who I teach history of psychology here at Millersville, and I had a student who reached out to Howard Dulley and had an email exchange with him for a couple weeks, and he was very gracious and very clear in his communications. So that's it. I think I'm at 15 minutes left, so I want to make sure I wrap it up there and throw it back to Kim and any questions you might have.